last patient, but the patient before. He is a director of a bank here, and his wife had a breast cancer, and he said, well, and she wanted him to come along and check your immune system, and I found prostate cancer in him, and a small one, but very aggressive. The Gleason score was 9. So pretty bad, and he was. And then we looked for an operation. He wanted to have that, okay, and he did an operation. Before that, he got cells. He got cells and immune stimulation by cell therapy. Then he went to the operation, and they didn't find in that point that he allowed a biopsy, which was not mine, yeah. But they did it, and he said, well, he was convinced that, oh yeah, yes, make that, and Gleason score 9, and we treated him, and 6 weeks after the beginning of the treatment, he had his operation, and he came back. Now the worst was a few cells with Gleason score 7, the rest was Gleason score 3.
After he had a prostatectomy?
Yeah, what he had, what they took out.
What they took out, yeah. And post operation.
Right, right. So the first was Gleason score 9, and then after the cell treatment and the immune stimulation, it went already down there to at the most. There was only a few with Gleason score 7, and the rest was Gleason score 3.
Have you treated men with recurrent?
Yes.
Cancer post either radiation or
right.
prostatectomy?
Yes, yes. A lot. We treat a lot of because a lot of patients come either normally either after operation or after radiation, and with their histology, pathology, and there we look, as I stated before, that we have to look for why this body allowed the prostate cancer to grow. So, and there we look for example for the immune system. If there are low immune system, we look for virus diseases, chronic virus diseases. We have herpes 6, very bad. Epstein-Barr is okay. It's not okay, but not that normally not that a problem in that case. But cytomegalovirus virus, and then we look after heavy metals. We find a lot of prostate cancer patients with heavy metal problem with lead, with mercury, and with aluminum, a lot. And if we address that, then we try to have on different sites. We attack on different sites. On one thing, we try to stimulate the repair genes. We stimulate stimulate and modulate the immune function. And then we try to get out the toxins, the heavy metals, and cut down on the virus load. And from that time on, we see regularly better immune function. We see regularly a better quality of life, and we see regularly a longer period of life as such. So statistics are there, but if we compare it, the combined treated patients, or just as normally the school medicine was just wait and see until a recurrence comes and then we can treat again, we see a lot longer survival time. And what we are doing, even if they are not, if people are, the patients are checked for any kind of bone lesions, in most of the time they find nothing, and the school medicine, well, that's fine. Oh, be happy, everything is okay. Nothing is okay, because the prostate is always an organ. It's a small organ. It's like the last meadow in a farm. So there are not a lot of immune cells are going there, but through the bowel movement, the bowel movement always gives a little massage on the prostate. So if there are tumor cells, before I cut them out or I have a radiation on it, for sure there are a few cells are going someplace in the womb or any place, and they are dormant there. And after a year, 2, 5, 10 years, they can still wake up, and that's why we stress on. We do definitely the biphosphonate, that Someta, once if they have no recurrence. So, and we saw, and that's meanwhile the statistics give us the right that we can say that we do it once a year or once every. It depends on the size of the prostate. We give it sometimes every 6 months for, let's say, a couple of years, and in addition with our cell therapy. Why? Because the stabilization of the bones are very important because of the dormant tumor cells which normally are there already. And if we do in addition the cell therapy, the immune function is really high. The natural killer cells are very active, and they can regularly check and monitor on dormant tumor cells, and as soon as they are recognizable, they kill it.
Wow.
Yeah.
What about a patient that is